All right. Can you see my screen?
Go.
Yes, Dokara, clear.
All right. With everybody's indulgence, I will turn off my video because you won't get any tips from the exam from my face, but on the screen. All right. So for trauma and critical care review, I am Koi. Um, let me see. This is me. Anyway, from this lecture, you're supposed to be able to identify trauma as a disease entity, enumerate the prioritization for trauma management. We'll go ahead with known protocols that are recognized in our country for the management of common cases, which will be very important, especially if they give you cases during the exam, to know the updated recommendations for trauma resuscitation and to understand basic concepts of surgical critical care, which the last lecture actually touched on already. So trauma is a disease comprising of 18% of the world's total diseases. This is from your ATLS. If you look at the slides, the pictures on your right lower part of the screen is actually the sources. So if you want to look up and read up more on those topics, you may well go ahead. So, still from the ATLS, this was the history of trauma. Before they were able to identify trimodal distribution of mortality, the first peak being almost immediately from the accident or the injury itself. And this can only be managed by promoting trauma prevention strategies. Your second peak is during the early part, a few minutes to the early hours of your trauma injury. And this is because mostly of your significant blood loss, so hemorrhagic shock and your TBI. With increasing protocols and management improvements of trauma injury, we were able to control this part of your trimodal distribution. The third peak comes a few days to weeks after, and this is already because of prolonged injuries and prolonged management of these patients, leading to sepsis and multiple organ dysfunction. So again, from a trimodal, because of improvement, especially in very developed trauma systems, we have been able to control this to just two peaks during the early minutes from injury and during the prolonged phase, which is still your sepsis and multiple organ dysfunction phase. So this is the approach to trauma according to your ATLS. We have to treat the greatest threat to life first. And we do this using the prioritization set apart by your ATLS. Never allow the lack of definitive diagnosis to impede the application of an indicated treatment. Lagi yan nakikipag-away tayo sa ER, sa emergency medicine because, wala pa naman kayong diagnosis. But actually, in trauma, we don't need it. We just depend on the injury pattern and we use it to identify we use the mechanism and the clinical presentation to identify injury pattern. And like the way we discuss patients that are yet to be worked up as kunwari, blunt abdominal trauma from a motor vehicular crash with possible injuries to the liver, to the spleen, depending on what part of the abdomen was mostly hit. So a detailed history is not essential to begin the evaluation of patients with acute injuries. So normally, what can we ask about trauma management? We begin with what are the high-risk situations that entails trauma center activation. So fall more than 20 feet, high-risk motor vehicular crash. Na it can be based on yung itsura ng car after the injury. So yung more than 12-inch intrusion sa passenger side, more than 18 inches in any side, ejection or death in the same compartment. Automobile versus pedestrian injuries are significant if the impact is more than 32 kph, and same with your motorcycle crash, 32 kph. But in the Philippines, who runs that slow, diba? 32 kph, chicken. Also, we also deem trauma injuries as severe or are high risk for severe injuries if there are comorbidities and in special populations, in the elderly, in children, in patients with the use of anticoagulants and with bleeding disorders, patients with burns, pregnant patients, and of course, kung sa tingin natin, even if it doesn't fall in any of those categories, based on the EMS provider judgment. So for your initial assessment, this is the ideal setting. There's a preparation, there's a triage that happens while the patient is already under trauma center. We have your primary survey, secondary survey, and definitive care. However, because our trauma system is yet to be mature, usually our management begins with a primary survey. Yung triage, dati nga guard lang yung gumagawa, diba? So, primary survey with immediate resuscitation of life-threatening injuries. So this is your normal trauma census slide, which puts forth the prioritization for your primary survey in the leftmost column, your secondary survey in your second column, and your noy-doy-toy-poy, and yung chart ng trauma injury. So for your primary survey, we begin with your A, airway and C-spine control. So we check and secure the patent airway and ensure cervical spinal motion restriction. This is according to your best adult trauma patient with risk factors or any high-risk injury pattern should receive oxygen at 10 LPM. So if there is airway compromise, either intubate or ventilate with due cervical motion restriction, reassess, and kung talagang hindi natin ma-ventilate or ma-clear ang airway, go to a cricothyroidotomy. If there's no airway compromise, you just repeatedly reassess the patient. So these are your adjuncts to your delivery of oxygen. This is your non-rebreather mask with your bag valve ventilation, your LMA, and your favorite EP tube. This is where you would insert your cricothyroidotomy. So remember that it's part of your A, the highest tier of priority for your trauma patients. You should include your cervical spine motion control. So kailangan, hindi mo kailangan ma-diagnose kung may cervical spine injury, kailangan lang based on your mechanism and yung presentation, kung sa tingin mo may chance, then do that restriction. Next on the tier of your primary survey will be your breathing and ventilation. As mentioned earlier, all trauma patients would be provided supplemental oxygen. And these are the big three lethal conditions for your ventilation. You have your tension pneumothorax, your massive hemothorax, and your cardiac tamponade, which are differentiated according to your best guidelines based on jugular vein distension, hypotension, and auscultatory findings. So there are ways to differentiate by way of your clinical presentation. But what do we need to do for at least for your tension pneumothorax and your hemothorax? It's actually pleural decompression. So depending on what you're actually considering, you can do your pleural decompression using your kneading, your CTT, or your three-sided occlusive dressing, which is for your open pneumothorax. Okay, C, for circulation. For me, yung ABC, yung tatlong pinaka-importante sa primary survey, kaya nga sila yung nasa top 3 years of discussion. Because pagdating sa circulation, or by that time, more or less dapat stable yung patient before you proceed. If your patient is not stable enough, or you encounter other problems, then you go back to your A, B, C bago ka mag-proceed with your DNP. So for your circulation, you check for confusion, perfusion, and pulses. Ito, hindi laging alam ng mga nag-e-exam, but essentially, based on your confusion, perfusion, and pulses, you get to have an idea what kind of, your patient is in shock, or what kind of shock your patient is already in. So, subtle signs, but clinically, there are already markers of shock for your patient. So once tension pneumothorax has been excluded as the cause of your shock, consider any hypotension that consider that any of your hypotension should be because of blood loss until proven otherwise. But you're not gonna depend on your CBC. Okay? You're gonna depend on the clinical picture of that patient. So this is a picture that I really like using. It gives us an idea of how much blood we can lose with injuries to those areas. Whether or not nakikita mo kung gaano karaming dugo yung lumalabas, whether it's an open injury or not. Remember that you can lose up to 2 liters in the chest by plain hemothorax. Hindi mo yan nakikita. Hindi siya apparent. In the abdomen, you can lose 3 to 4 liters. Especially in blunt abdomen na wala siyang lalabas ang sugat. In your pelvis, 4 to 6 liters. In the extremities, 1 to 2 liters. And you only lose about 30 cc, 30 ml of blood in the head. So hypotension due to a TBI is unlikely. Kailangan mo work up mo na may ibang causes ka ng hypotension. So there are about just 2-3 tables that I need you to memorize. This will be one of them. This is, of course, a table from your ATLS. This is the most updated one, wherein we include the base deficit coming from your ABGs to classify your shock by class 1, 2, 3, and 4. Lagi, yan may tanong, at least is your ATLS also tries to classify your patients according to their response to resuscitation. There are rapid responders, transient responders, minimal or no responders. This will just help us to clinically assign patients who will be needing transfusions and surgery. So of course, your rapid responders may not necessarily require surgery, not even blood transfusion. Your transient and minimal responders have a high risk for transfusion requirement and surgery.
What's the rule?
So touching on the resuscitation part, early and aggressive resuscitation with crystalloids was the rule, because now you recognize that there are a lot of problems with giving your patients too much crystalloids. This include hemodilution, acidosis, and hypothermia, including an intense inflammatory response that can lead to your ARDS, your MOF, your endothelial dysfunction, dysfibrinogenemia, and platelet dysfunction. Also, na-recognize natin na the leaky bucket model. No matter how much we give, expect the water that we are trying to put intravascularly to stay intravascular, because there are holes, there are injuries that are working against us. So what do we use now as a model of resuscitation? It's called hemostatic resuscitation. We try to control the hemorrhage while maintaining adequate perfusion. We balance it out to effectively prevent coagulopathy, acidosis, and hypothermia, your triad of death. So aggressive resuscitation to stop the bleed. We employ pressure dressing, tourniquet, your REBOA, and your early hemostatic surgery. For your blood product resuscitation, please know that your ideal blood product resuscitation will be your liquid cold stored, low titer, type O whole blood na ang best natin. So as we go down in this listing, nagiging less ideal na siya. And we have seen that the pre-hospital use of low titer O whole blood has been associated with decreased trauma bay mortality, and even the use of pre-hospital plasma has been associated with improved overall survival. How do we transfuse if we don't have your low titer O whole blood? We transfuse in a 1:1:1. 1 unit pack RBC is to 1 unit FFP is to 1 unit platelet, trying to reconstitute that whole blood scenario. So also under resuscitation in your circulation, you have to know that the ideal delivery of your tranexamic acid will be a gram bolus and followed by another gram delivered over 8 hours. Yung ginagawa natin usually na 2-gram bolus is actually from the military standpoint, but in your ATLS, it's actually a gram bolus followed by an 8-hour drip. But ang caveat nito, huwag kang magbibigay if your patient has been injured for more than 3 hours already, because there have been studies that have shown that giving tranexamic acid more than 3 hours from injury can be deleterious to your patient. So ang magic number, 3 hours. Okay, so this was what I mentioned kanina. You have your trauma triad of death, which is actually your hypothermia, coagulopathy, and acidosis. At this point, when you reach these parameters, hypothermia, acidosis, and coagulopathy, the chance of mortality is raised 10 times. So, ang goal natin, hindi tayo makaabot dyan. Kaya nga, nagre-resuscitate tayo before another insult. But good to know that you have the lethal triad is now being developed into a lethal diamond. Dahil naman sa dumadami ng blood transfusions, we're starting to recognize the value of giving your calcium to address hypocalcemia. 1, because of trauma itself, and 2, because of the bank blood, BANKED, bank blood, na binibigay sa patient. If you have any questions, just put on the Q&A box at any time. So we go on to your damage control surgery, which is still part of circulation kasi nga hindi ka aalis ng ABC kung hindi pa stabilize yung pasyente mo. So C, part of your hemostatic resuscitation, is your damage control surgery, a deliberate and calculated surgical approach to maximize the physiology of your patient prior to definitive repair of your overwhelming injuries. So, tatlo yun. Degree of physiologic insult, estimated blood loss, and injury pattern identified, which will trigger your use of damage control surgery. So, for your damage control surgery, you have 3 phases. Phase 1 is yung mismong surgery, yung DCS mo. So, control of hemorrhage, control of contamination, and temporary abdominal closure. Phase 2 happens when you recognize that your patient cannot do a definitive or a long surgery and you have to bring your patient to the surgical ICU or in a unit where you can resuscitate your patient using rewarming, correction of coagulopathy, maximizing hemodynamics and ventilatory support, and to further identify injuries para pagbalik mo sa kanya, pag-open mo ulit ng abdomen, targeted yung activity mo, which will be the phase 3, your pack removal and doing your definitive repairs, because you know at this point that your patient can survive these injuries and your additional insults better. So damage control approach is a mindset that begins in the first 5 to 10 minutes of evaluating that patient. Meaning, sa ER pa lang, pag nakita mo na masyado nang marami yung blood loss, your patient is in extremis, at nasa mindset mo agad yung option na damage control, na all you want to do is to quickly control the bleeding. The best and surgical anesthesia team available should be employed for the damage control surgery. And it requires that you have a critical care team and unit, may it be a surgical ICU or a post-anesthesia care unit, which is also an ICU level of care that it can provide. And it does not necessarily require fancy gadgets. It would rather require the critical care team and having a low threshold for applying damage control approach. So, tutuloy lang tayo sa letter D only if you can, only if stable na yung patients mo. Paulit-ulit kong sinasabi kasi importante yun. So, we only proceed to identifying disability kung okay na or relatively stable na yung patient mo. Disability is defined by the level of consciousness based on your GCS, your pupillary size and reaction, and presence of your lateralizing sign. Kung meron, we use your Asia classification to identify the level of the spinal cord injury. So this is the table that I need you to know kasi lagi din siyang may tanong, computation of your GCS score. So this is of course the GCS for adults. For yung sa part. So your eye-opening, verbal response, and best motor response, which is best studied as a prognostication for your trauma patient. Essentially, what is this? It identifies your Monroe-Kelly doctrine. So, these are, ito, screenshot nyo na lang. Minsan may lumalabas pa isa-isa. So, there are indications for surgery according to CERES. So, kayo makipag-away sa neurosurgery based on this. But at least know that there are surgical indications for each of your TBI according to Schwartz. E will simply be for the limitation and prevention of hypothermia. So you expose your patients, but please make sure to rewarm those patients afterwards. Cover them in warm blankets once you do your adequate exposure. Because you see, we lose a lot. We expose those patients and we lose a lot of your temperature to the environment. Sorry, I will pause with the question of before I do to this topic. Good morning po, Dr. For the tranexamic acid, does the 3 hours limit also extend to not giving tranexamic acid post-op? So, no, yung 3 hours rule is actually just for the initial trauma. Kasi yung idea na hindi mo pa na-work up yung patient mo based on your mechanism and based on the presentation, you will have to give your tranexamic acid, especially for a patient that is in shock. Pero post-op kasi, one, you want to limit the use of your tranexamic acid kasi supposedly, na-control mo na intra-op kung ano man yung nag-bleed. And before mo naman i-close yung patient, you would have been more confident with hemorrhage control. Number 2, unless alam mo na meron ka pang naiwang bleeding, and then that becomes a problem. Kasi dapat di mo siya sinara. So, your adjuncts to primary survey will include your chest x-ray and EFAST because they give you windows to compartments that may not be bleeding overtly. Your chest x-ray for the chest, your EFAST for the pericardium, and your abdomen. So your other adjuncts will be your ECG, especially for a blunt cardiac trauma, your pulse ox, your capnograph, your ABGs, and your decompression of your stomach and bladder. Okay, so for surgical approach, your laparotomy, again, we try to identify and treat the greatest threat to life. This is true for your damage control surgery, wherein your priorities and objectives is to control your hemorrhage contamination by your viscous injury and to identify all other injuries, especially yung solid organs, the liver, the spleen. And then there's no one algorithm that fits all trauma patients. So, kaya nga lagi siyang may caveat na depending on the judgment of your EMS provider also. But now, at least we recognize that there are issues that goes beyond your anatomy. So, sometimes it's the physiology that is the better marker of survival. Kasi hindi lang tayo basta nag-stitch up ng mga patients. Gusto natin na address natin holistically yung patient. So that should include your physiology. Okay, so we're going now to the trauma protocol. Sorry, medyo laki talaga yung coverage for trauma and critical care because it starts from your initial management to identification of trauma injury pattern and to your surgical crit care management. So for blunt cardiac injuries, you have you diagnose it if there are based on mechanism plus unexplained tachycardia, murmurs, abnormal diagnostics on your ECG, troponin, and 2D echo. So what is the standard of care is to do your ECG. Paano naman kung penetrating injury to the cardiac box? So, depende yan kung kamusta yung status ng patient mo, whether normotensive or hypotensive. Kasi kung hypotensive din at alam mo na cardiac box injury, then you have no issue to work this up. You have to bring that patient for a thoracotomy. Sa exam, ang laging sagot ay thoracotomy because your pericardiocentesis is only a temporizing procedure. So, kung normotensive, you can do a chest x-ray and a 2D echo or at least a pericardial ultrasound to identify the presence and absence of your pericardial fluid and the amount para sa definition mo whether your subxiphoid window or thoracotomy. The reason, especially in the Philippines, that we adopted subxiphoid window is the high prevalence of TB patients. So for a blunt chest injury, again, ang tipping point mo will be your hemodynamic instability, whether it becomes, kasi kung blunt chest, we are thinking of tension, pneumothorax. Kung nag-bleeding ka, you have to do your CTT. Kung hindi siya tension, is it massive pneumothorax? So dapat pleural decompression, pero not by needing, but rather by a CTT as well. Not all blunt chest injuries need your pleural decompression, though there are those that will only appear na nagkaroon ng blunt chest injury based on your workup already on your chest x-ray kasi stable yung pasyente. So yung mga pasyenteng yun, depending on what you see with a pneumothorax of 20% or pneumothorax more than 200 cc, that's when we intervene. Otherwise, we can observe. For penetrating chest injuries that are not in your cardiac box, so again, hemodynamic instability ang tipping point, and then you can work them up kung stable. So your chest x-ray. For your blunt abdominal injury, we want to again use hemodynamic instability kung unstable. You do your exploratory laparotomy. Kung blunt, mas mataas kasi yung threshold natin na i-work up muna based on abdominal PE. Kasi konti lang ang nagpe-present with florid peritonitis agad. So we can either do fast. If positive, you can proceed with your CT scan or DPL. Kung negative, pwede mo lang siyang bantayan for 24 hours. Meaning abdominal PE, and your work. Non-operative management must only be used if all of the following are available: your surgical ICU, 24-hour operating theater, blood bank, and imaging is available to you almost 24/7. Otherwise, kasi we're gonna expect some delay. Non-operative management must be terminated at any point as long as you meet any of these criteria: hypotension, signs of hollow viscous injury. So, peritonitis, development of septic syndrome despite normal abdominal findings, and deterioration in vital signs despite resuscitation. So for penetrating abdominal injuries, these are your indications for your laparotomy. For equivocal abdomen, what can we do for your penetrating abdominal injuries? We can do your serial physical exam, diagnostic peritoneal lavage or DPL, local wound exploration if it's in the upper part of the abdomen. Ultrasound, CT scan, and screening, laparoscopy. DPL is positive if there are gross feces, bile, and food particles, and if the RBC count is more than 5,000. For colonic guidelines, ito, hindi natin masyadong nakikita with practice, but we do know that there are colonic guidelines to differentiate between non-destructive and destructive colonic injuries. So, i-differentiate mo lang siya. But, mamaya. So, the definition of peritonitis is very varied. Inflammation of the peritoneum or serosal surfaces as evidenced by congestion and edema and presence of fibrinous purulent or fibrino-purulent exudates or frank abscesses. But kasi, kailangan mo pa rin malaman na whether we see those non-destructive or destructive injuries with or without peritonitis, we still depend on your primary repair of injuries as much as possible. So for your penetrating injuries to the back, simple lang yan. If there are no abdominal physical exam findings, then we do not do anything. No workout. Get? So, penetrating injury to the back, ang definition ng back being posterior axillary line to posterior axillary line. Anything other than your back is your abdomen. Wala nang definition ng flank. So, back is for your posterior axillary line to your other posterior axillary line. So, kung may stab or penetrating injury to the back, tapos walang abdominal findings, then wala tayong gagawin. Kung may abdominal findings, that's when we explore. For penetrating neck injuries, it is imperative that we do physical examination, chest x-rays, and cervical x-rays. Hard signs, ito yun, lagi nating tinatanong. Soft signs will be hematoma, hoarseness, and neurologic deficit. Very busy slide, but essentially, ang gusto lang natin malaman kung may neck injury, ideally, ma-work up natin yung pasyente unless, frankly, hemodynamically unstable siya. Meaning, vascular yung problema. Then, there's no point monkeying around with diagnostics. Yun, iakit mo. But otherwise, kahit sabihin mo na parang, nahihirapan siyang huminga, then intubate that patient. I think there's a tracheal injury, then intubate that patient. That would have been enough to tide over your patient and then work him up. Para targeted yung pag-explore mo ng neck.
Or pretty much sa nomads. Naman sa level. But ang space. Dog.
O, may
Gcash lang
10,000.
Pero wala yung 10K.
Namin Gcash.
Yung oras ba, bayaran ko mo, virtue. Tungan ko 30,000.
Oh my God, kamahal.
Isa daw ang
Gcash mo na ko ibayad.
unsa ang
Insurance.
Sir, nawala ata si Dr. Akoy.
Hanapin mo, sir.
maglago kay ko ano. Ano yung sa store.
Mag-send mo na sila PDS, no?
Wala ba si Dr. Akoy? Doktora, tayo ko tawagan, tayo ko.
Sa picture sa tutbay. Sa
Nananawag na doktor.
And to the participants,
Tora, ano
please
na?
excuse us for the technical difficulties now.
katong si ano
Might be a connection problem.
Siya ang sa best na lecture to COVID. Nag-video sa mga labs. Ito yung valor ba ko nagbalay bitaw. Oo, sige ito. Ito na kasi mga resident. Sumong lang ba siya na lecture sa di ba?
Sige, sige, bro.
Siguro ganun itong sa Brini, no? Katong sa matutulog.
Hi.
So while we are waiting for Dr. Akoy to reconnect, there are already two pending questions here in the chat box. So after her lecture, I will be asking her these questions. So yung una is ano po yung mga examples ng non-testable scores sa revised CES. And yung isa is, Doc, the patient arrives more than 3 hours post-injury. Do we let go of both the tranexamic acid bolus and drip? Or is it still prudent to give the patient the Tranex script? So I think this third question is related to the first question earlier answered by Dr. Akoy. No? So we'll just wait for her, and after the lecture, we'll get her answer. So for the participants, please type in your questions in the Q&A chat box na, so that later we'll just read your questions and answer them.
Sa C-Flex day sila na ngayon.
Oh.
Yan mo tuyo ka. Pabalik ko.
I know it's already 12 noon, and it's been a busy Sunday morning for everyone. So please bear with us. I think this will be just a few more minutes. Thank you.
Let's play a video from our sponsors muna kapag wala. Andyan, she's already come back. Hi, Koy.
Ayan, yes, sir.
Hello, sorry.
Hi, Dr. Apoy.
Hindi, di ay pre-record.
It's okay.
Hindi siya okay. Kisa to. Wala na sa job.
Oh, sorry, that's the wrong screen.
7 of 113 slides.
It's the wrong screen. Uy, nakita
So,
yung
so
mga
your-
kuan.
Yung ba siya hours?
Yung bit mo kamit niya.
There. What screen do you see?
Hindi ko yung...
Dili man i-put screen record ang audio sa computer.
Babae ka diyo.
Penetrating neck injury.
Huwag na siya, no?
Yes, sir. But you see the screen share properly na?
Kita
Yes, Doc.
namin.
Yes, okay. But where did you lose me? I'm sorry.
We didn't lose each other.
Screen.
Okay to start here or previous slide?
Yung previous slide, Dr. Rice, the algorithm ba?
The previous slide is just this one, the list of
Ah,
your
yeah.
injuries.
I think dyan medyo nagkaroon
Okay.
ng
Sorry. So for injuries,
Okay, thank you.
we just have to know that for your carotid, you want to repair at all times unless your prognosis is poor. Your vertebral arteries, you can ligate if at least isang side. Venous injuries, ligate plus or minus reconstruction. For your esophageal injuries, you want to do primary repair and drainage, but the golden hour is about 13 hours lang. Tracheal injuries, you do primary repair with or without prolonged intubation. Your combined tracheoesophageal injuries, you want to repair and do a buttress, meaning meron kang something, a muscular buttress to go in between your two structures, your trachea and your esophagus.
Ako din bilang na mabatras kay mental batras.
So, penetrating neck injuries may be managed by selective or mandatory exploration. We are moving to a more selective exploration nowadays. Yun nga yung sasabi ko na more of vascular lang yung immediate exploration. And kasi we recognize that there's a decreasing number of neck exploration. So yung confidence and yung volume din per hospital is decreasing. So it becomes a little more safe or safer for your patients to do a selective neck exploration. So you do emergent operation dictated by physical findings related to hemodynamic instability and gross bleeding. So your zonal classification may aid in management considerations and enlisting additional expertise kung NSS and TCVS. Yun na lang ay actually yung use ng neck zones mo. We are moving towards decreased use of your zonal injuries. So, although varied in definition in different situations, hard science mandate emergent operations because these are attributed to your vascular concerns, while soft science mandate expeditious workup. Okay,
Pediatric, pediatric, hindi nawa na sa tinatulog.
L per tumulus of isotonic crystalloid followed by transfusion. Blood products already, 10 to 20, 10 to 20. Yung 20 ml per kilo is actually new, comes down from a 30 cc per kilo ng crystalloid. So parehas lang sa adult, we're shying away from massive delivery of crystalloids. Part, you have about 10 questions coming from your surgical ICU part. Some of it include your electrolyte corrections and your resuscitation. So, medyo mas mabilis na lang to. Siku potpourri. So, you have your fluids and resuscitation. There is still no fluid that is hands down the best for resuscitation. No such fluid yet because depending pa rin sa situation with your patients. Whether usually we do an isotonic fluid which was before which was your plain LR or your plasma lamp. And depende na lang kung meron talaga tayong ibang prescription, that's when you use your plain NSS, say a traumatic brain injury patient or a renal patient with a elevated potassium. So plain isotonic fluid closest to the osmolality of your blood ang pinaka-ideal pa rin.
Elevated potassium mag-NSS.
So fluid resuscitation, early versus late. When it comes to selecting the fluid resuscitation, there is a wide range of options. However, superiority is based on a lot of debate. So, first, shock rarely happens in isolation, especially pag nasa setting ka na ng CU. This is different from your acute trauma wherein most likely it's either tension, and if it's not tension, it's hemorrhagic shock. So, you have no issue. Ang best resuscitation fluid is blood. Pero in the ICU, hindi na siya in isolation likely. So, it can either be may halo na siyang sepsis, may halo na siyang blood loss, hemorrhagic shock, ano. So, second, endpoint of resuscitation remains unclear. I would love to be able to tell you na ito, stop na ang fluids, ito, ganyan. But essentially, the end goal is that you try to maximize your intravascular volume para yung cardiac output mo is at its best. So their endpoint of resuscitation in a theoretical standpoint is when even if you give fluids, hindi na magbabago ang cardiac output mo. That is based on your Frank-Starling curve. Third, the goal is to optimize, so ito yon, cardiac preload to deliver the best stroke volume to your end organs. So that is essentially resuscitation, improving your stroke volume and delivery to your end organs. So, nandun ka sa endpoint ng resuscitation kung kahit anong dagdag mo, hindi na significant yung improvement in the delivery. So, optimizing does not necessarily mean maximizing fluid delivery. So, as Sir mentioned kanina, we are into goal-directed fluid therapy already. And we use circulatory surrogates that allows us to maximize stroke volume. But it does not necessarily mean more means better. So, dati, we use your PCWP and your CVP as your endpoints of resuscitation. However, we know now that these are very static and it doesn't change based on your patient status and hindi siya clear picture in time with your heart. So, new are your dynamic parameters, which can be your systolic pressure and your pulse pressure variation. So, kung gaano na siya ka-variable, meaning paiba-iba na siya. At kung malaki pa rin yung difference when you give your fluids, ibig sabihin, meron pa siyang additional benefit of giving your fluids. Pero kung wala na, hindi na siya ganun ka-variable, even if you give your fluids, then yun na yung maximum ng dapat mong ibigay sa fluids mo. This is what I've mentioned earlier. This is your Frank-Starling curve. So, you want to be able to be at a point in the curve wherein when you give fluids, there is a huge response to your stroke volume, meaning, how pa yung system mo for fluids. However, if you give fluids tapos hindi naman na ganun kalaki yung improvement in your stroke volume, meaning wala ka nang nakikitang ganun kalaking variation in your parameters, then your fluid resuscitation is enough already. So when to stop giving your fluids, if there is a high ratio of your ejection fraction and diastolic volume, there's a low pulse pressure variation, hindi na siya paiba-iba, hindi na siya ganun ka-sensitive, there's a negative passive leg raise, and your lactate is actually normalized. And then when do we remove fluids? So magkaiba na siya ngayon yung kailan ka titigil mag-resuscitate at saka kung kailan ka mag-de-resuscitate. And we actually like that word, especially in the surgical ICU, because we recognize that from the hints of our history with our fluid resuscitation, minsan napapasober talaga. So, you also need to be sensitive of when to de-resuscitate your patient. De-resuscitate. So, your high extravascular lung water index, yung magana, high pulmonary vascular permeability index, tumataas na yung abdominal pressure mo kasi tigas-tigas na ng tiyan mo, kaka-resuscitate. Low abdominal perfusion, meaning nagkakaproblema ka na parang ang presentation to, pumapangit ulit yung base deficit mo kahit na maganda na yung hydration status mo clinically, your positive cumulative balance. So this is basically your I&O. And know that the best fluid may be actually the one that was not given to the patient because we're not trying to make a Michelin man out of your patient. We're trying to just resuscitate and improve his physiology. So you get to a point also that your additional fluids become detrimental to your patient. Okay, arterial blood gas. It is very important because they will be asking arterial blood gas for your exam. Sir has touched on this, on your normal values and on the interpretations of your arterial blood gas, as it gives you an idea of your ventilation, oxygenation, and your acid-base balance. So essentially, ito lang din yung sa ABG, this was mentioned kanina, You check validity, your pH, disorders, compensation, and an ion gap, which is significant kung metabolic acidosis. Kung hindi, forget about it. Shock. Shock in the ICU, at least in the surgical ICU, will most likely come from septic and septic, cardiogenic, and hemorrhagic shock. So, septic shock, kailangan yung updated sa diagnosis. This is a life-threatening organ dysfunction. So, kailangan sa sepsis 3 diagnosis, meron ka ng organ dysfunction caused by dysregulated host response to a diagnosed infection. Septic shock is now defined as a subset of sepsis with circulatory and cellular metabolic dysfunction associated with a higher risk of mortality. So essentially, manage of sepsis and septic shock, managing infection, your supportive measures like mechanical ventilation, managing your resuscitation, and improving the sepsis management programs. So ang surgeon, syempre, papasok yan sa managing of infections, but essentially, we're trying to improve the how surgeons contribute to that management of sepsis by improving on our surgical critical care programs. So last will be nutrition. This is a very big part of your crit care part for your exam kasi we have been able to identify that perioperative malnutrition has been proven challenging to define, diagnose, and treat, and it will spell a very different outcome for your patient kung hindi siya na-manage ng maayos. So, nutrition and upbuilding is very difficult to diagnose and even define kasi malnutrition, undernutrition, frailty, sarcopenia, iba-iba siya. But essentially, they all spell a very a worse outcome for our patients. So there are a lot of scorings available. Essentially, you just want to be able to identify patients who are high risk for malnutrition using your Nutric score or your nutritional risk screening or your NRS or your SGA. Tatlo sila. So, Nutric, NRS, SGA. Lahat sila will just give you an idea whether your patient is at risk. Yun lang. Kailangan mo lang malaman at risk. Kasi kung at risk, you can already enlist the help of your clinical nutrition, your surgical crit care, you can enlist the help of your rehab. So, kailangan lang ma-identify. Indirect calorimetry is the gold standard for determination of energy requirement. However, syempre sa exam nyo, what we always still use is the numeric. Kasi hindi naman namin kayo mabibigyan ng indirect calorimetry values kasi ibig sabihin, yun na agad yung requirement niya. So we still use your 25 to 30 kcal per kilo per day as a target calorie requirement and your target protein to be anywhere between 1.5 to 2 grams per kilo per day for your surgical patients. Refeeding syndrome. This, I think, is nearing the end of the topic. So for the refeeding syndrome, essentially, we just want to identify those patients who are high risk for refeeding based on these risk factors para ma-modify natin yung delivery. Kasi dahil na-realize natin, nutrition is very important for your operative outcomes. However, hindi naman lahat ng patients nyo kailangan ng TPN na 1/4 kcal agad-agad in 24 hours kasi hindi napapakain. Refeeding syndrome is delivery of too much, too fast, leading to metabolic irregularities that may spell cardiac complications for your patients. So, ideally, we have to stratify whether your patients are at risk for refeeding to fine-tune the delivery of nutrition, especially for the early days post-operatively. So we stratify, we feed slowly, hindi tayo nagmamadali. We have your 3-day mark and 7-day mark, and then we monitor closely. Okay, so that was a mouthful of a lecture, but I've prepared questions that we can tackle. So this was actually in a previous slide. Once tension pneumothorax is ruled out, the primary consideration for shock and trauma is letter D, your hemorrhagic shock. In a case of a blunt trauma to the chest with a finding of 10% pneumothorax on initial X-ray with maintained hemodynamic stability, so stable patient with a chest X-ray finding of 10% pneumothorax in a setting of blunt trauma, what should we do? We need to just observe. 10%, So for this question, this is the case. 28-year-old male transferred to the institution uncoordinated after a motor vehicular crash. He was an intoxicated pedestrian hit by a tricycle. On admission, patient has the following vital signs: hypotensive 80-50, tachycardic at 128, RR is 33, autosat is 97%. Patient is drowsy, moaning with eye opening and withdrawal to pain. He is bleeding from a deformed left arm. What category of shock? Hypotensive na siya. So, automatically, minimum class 3. Okay? So, pag class 3, ang pwedeng next question dyan, ilang percent ang expected blood loss na, or how much, ano yung base deficit na ine-expect, mga ganun. That's why you refer to that table na pinakita kanina. For that same patient, what will be the GCS? Remember, patient was moaning with eye opening and withdrawal to pain. So, E2, D2, M4, which is your CS8. So, yan yung second table na pinapamemorize ko. What is your first priority in resuscitating this patient? This is actually a trick question kasi lagi siyang tinatanong. So, how will you resuscitate that patient? You always begin with your ABC. So, A pa rin. Clear the airway. And random question that I added for the crit care part, what is the initial priority in managing refeeding syndrome? It's actually still your screening. Kasi yung nutritional support or withholding nutritional support may not necessarily be what you need to do. Kailangan ma-screen lang kung sino ang high risk or at risk for refeeding syndrome. Alright, that should be my last slide. Sorry na, disconnect ako. So